Welcome to AETCM. Today I'll be presenting a case of a 67-year-old female who came to the ER with complaints of dry cough for the past 10 days. The cough was intermittent in nature, not associated with any sputum expectoration, and there was no diurnal variation. She also had associated chest pain on the right side, which worsened while coughing and on taking deep inspiration. There was no complaints of fever, sputum production, rhinorrhea, sore throat, hemoptysis, or shortness of breath. There is no past history of pulmonary TB, asthma, obstructive airway diseases, allergies, pneumonias, or malignancies. Patient had no history of recent travel or exposure to any dust or allergens. There is no family history of TB or malignancy. Patient is a known case of hypothyroidism on tablet thyroxine 50 mg since 20 micrograms since 2018, and is a known case of systemic hypertension on Telma 40. Surgical history: patient had hysterectomy done in view of heavy menstrual bleeding. So based on my history, the patient, to summarize my history, the patient came with dry cough and right-sided chest pain for the past 10 days and known comorbids of hypothyroidism and systemic hypertension. So based on my history, the differential diagnosis that I would consider is that it sounds more of a pleuritic chest pain. So I would initially consider a case of a patient with pleural effusion and pleural effusion unilaterally. The other differentials would possibly be an interstitial lung disease, but the factor not favoring it is that there should be some progressive dyspnea over a long period of time. The differentials like pneumothorax and pulmonary embolism would have acute onset dyspnea, which was not present in the patient's case.
But pain is the major factor here. Can you get pain in ILD?
No.
It is not a feature.
Yes, sir.
What are the conditions you get pain during inspiration in lung disease? One you rightly told pleuritis and pleural effusion. That's correct. What is the age of the patient?
67.
Okay, so what are the other conditions which can mimic this? Chest pain, on breathing increases.
Costochondritis.
Huh?
Costochondritis.
Okay, costochondritis. Anybody can have costochondritis. Then? What next? What? Malignancies. Rib infiltrations. That is one of the common problem in elderly individual who can have prostatic enlargement. Male, no?
Female.
Sorry, this is female.
Yes.
Or breast involvement. They can have rib problems. So this is one of the closest differential diagnosis for pleuritic pain. That is not a pleuritic pain, actually it's a rib pain.
Yes.
Many patients you can see malignancy with rib infiltration. They come with severe pain on breathing. Okay.
Yes.
There is another differential diagnosis. Or rib fractures.
Yes.
Sometimes you can get rib fractures. Minor trauma can produce rib fracture in elderly individual. Osteoporosis. Okay. So these are differential diagnoses we should just think. Can you get herpes zoster? So that is also differential diagnosis for such pains. Okay. So it's your duty to examine the skin of the patient, muscle of the patient, bone of the patient during the clinical examination.
Yes. So moving on to the examination. Patient was conscious, oriented, afebrile. There was no pallor, icterus, cyanosis, clubbing or pedal edema, no visible swollen lymph nodes. Vitals, heart rate of 64 beats per minute, saturation of 96% in room air, systemic BP of 120/70 millimeters Hg, and a respiratory rate of 20 per minute. On arrival to the ER, the initial ABG was normal, and the point of care CBC was non-remarkable. Moving on to systemic examination, cardiovascular system, S1, S2 heard, no murmurs. Per-abdominal examination, soft, no tenderness, no organomegaly, surgical scar present. CNS, no focal neurological deficits.
Surgical scar present or not?
Present.
Where?
The hysterectomy.
Hysterectomy surgical scar.
Yes. And moving on to respiratory system proper. Upper respiratory tract, normal nasal mucosa, no septal deviation, no polyps. Oral
Hysterectomy was done for what?
The heavy menstrual bleeding, sir.
Okay. Not for malignancy.
No, sir. Oral cavity, good oral hygiene, no dental caries. Inspection of the chest, bilateral symmetrical chest wall, no spinal or sternal abnormalities. Trachea appears to be in the midline. Chest movement was noticed to be decreased on the right side.
So here also spinal tenderness is very important. Whenever you may be a pulmonologist, but when you are examining, you have to see spinal tenderness in an elderly female patient, pleuritic pain, spinal tenderness, breast examination. All these things are very important. Axillary lymph nodes.
Yes, sir. Chest movement appears to be decreased on the right side. No shoulder drooping or chest retractions. No supraclavicular fullness, dilated veins and sinuses, or pleural tapping marks. On palpation, the inspectory findings were confirmed. Apical impulse was located at the left fifth intercostal space, half inch medial to the midclavicular line. On percussion, there was a stony dullness noted on the right mammary, right infraaxillary, right interscapular, and right infrascapular regions. On auscultation, the above mentioned findings were confirmed. There was reduced air entry on the right side.
Whole right side or only in the infrascapular area?
So only in the infrascapular area. So the patient had taken a CT chest outside the previous day. The CT chest showed a right-sided massive pleural effusion along with atelectasis of the right lower lobe.
Okay.
And in the ER, a USG chest was performed where anechoic areas were found with a jellyfish sign showing lung collapse, underlying lung collapse.
Okay.
So for further management, the blood investigations were sent. And
so normally in clinical books you may read above the pleural effusion you may get a bronchial breath sound. That is because of this collapse.
Yes.
But we never get all these things. It is given in books that you can get a bronchial breath sound just above the pleural effusion.
Yes.
That is mostly because of the collapsed lung fields. Okay. But it is practically impossible to get a bronchial breath sound in such cases.
Yes, sir.
Okay.
So blood investigations were sent, and the INR and pre-op serology came out to be normal. So we proceeded with pleural fluid aspiration. So proceeded to investigated pleural fluid aspiration for both diagnostic and therapeutic purposes.
Why should you do pleural aspiration for therapeutic purpose?
So there was moderate effusion. So on draining out most of the fluid, the lungs would re-expand and the patient's symptoms would come down.
Okay. Is there any symptoms because of pleural effusion?
There wasn't dyspnea as such,
okay.
But
so in emergency room, what are the indications of emergency pleural tap? Emergency room. He is told rightly, patient is having collapsed lung, so it is better to remove. But some patients will not wait for any investigation. We will have to remove. What condition you will remove? Sleeping.
Severe dyspnea.
Severe dyspnea. In a patient who is having severe dyspnea, distress, then better to tap the fluid. Otherwise, patient same like ascites. We tap the fluid when the patient is having severely dyspneic.
yes, sir. Even in massive effusions.
Massive effusion, it is not an emergency. You can take your own time. If the patient is symptomatic, then it is an emergency. You have to remove it fast. Otherwise, patient may go to respiratory distress.
Yes, sir.
Okay.
So 500 ml of fluid was drained. The fluid is hemorrhagic in appearance.
So in that this one context, I am asking you, what is compensatory emphysema?
So because of the lung collapsed on one side,
so normally when there is a progressive collapse of lung, the other side of the lung, the opposite side will expand in the limits. It is called as in the limits means it will not expand more than the limits. So your dead spaces or collapsed alveoli, everything will be opened up. So in that case, if you take an X-ray, you can see one side will be blackish.
Yes.
That is called as compensatory emphysema. So many of these patients may not be symptomatic in a progressive development of pleural effusion. If it is a rapidly developing pleural effusion, this may not happen. Patient will be breathless and you will have to immediately remove the fluid.
Yes, so 500 ml of hemorrhagic fluid was drained. Then
what are the reasons for hemorrhagic fluid?
So hemorrhagic fluid.
Is it traumatic or hemorrhagic? What is the difference?
Sir, we'll have to first check if the blood, check if the pleural fluid is clotting or not. If it actively clots, it could indicate a traumatic tapping.
Traumatic. If it is clots, then it is mostly traumatic.
Yes, sir. Then we send the fluid for hematocrit, and if the hematocrit is if the hematocrit is more than 50% of the serum hematocrit, it's suggestive of hemothorax. If it's lesser than that, it's just hemorrhagic fluid. Sir. So in this case, we had sent for hematocrit, and it is suggestive of hemorrhagic fluid, and it did not clot on.
Okay.
Then
so what are the differential diagnosis for a patient who is having large amount of blood in your thorax? What is the differential diagnosis?
So trauma, any RTA trauma.
She had never given history of trauma, so RTA can occur. Lung malignancy is one, but before that, anything else can produce blood in the pleural fluid. One is lung malignancy, rightly you told.
Aorta
rupture is not very common.
Traumatic.
We all learned tuberculosis is a straw colored, but tuberculosis is one of the common cause for even hemorrhagic. Okay, so chronic inflammations can produce hemorrhagic, but rightly told, malignancy is the first thing should come to our mind. So malignancy is the most important reason for that.
Yes. Okay. So the fluid was sent for biochemistry and microbiological studies. So the biochemistry studies, it showed a LDH of 410.
Okay.
Protein of 5.14,
Okay.
glucose of 95, ADA of 13, and total counts of 18,850.
What does it mean?
So based on this picture and applying Light's criteria to it, so the LDH, the pleural fluid LDH ratio to the serum LDH should be more than 0.6. If that's the case, it's exudative.
Okay.
And in our case, the fluid LDH
is very high.
Yes, sir. The fluid LDH was 410, while the body fluid LDH is 185. Okay. So it was more than 0.6. And when it comes to protein, the protein is 5.14.
So that's also high.
And so it was indicative of an exudative.
Okay. So it is something inflammation, active inflammation is there.
Yes,
okay.
Sir.
So can it be malignancy?
Yes, sir.
Still malignancy is one of the common cause for exudative.
The CT also showed.
But ADA you told before.
So ADA was 13.
13. What is the importance of ADA?
So in cases of TB, when it's more than 40, it's suggestive.
Well, it can be suggestive of tuberculosis. It is more than 40. What are the other conditions you get elevated ADA? Other conditions. ADA is not a foolproof diagnosis for tuberculosis. There are other conditions. Empyema is one condition where there is lot of pus, it can produce ADA elevation. Pulmonary embolism sometimes can produce ADA elevation. But classically, we all learned that tuberculosis means more than 40 is tuberculosis. Probably tuberculosis associated features, but it can be elevated in many other conditions also.
Yes, sir.
Okay. Can you do ADA in ascitic fluid and CSF?
Yeah. Ascitic we can.
It is not useful. It is mainly useful in lung disease, but we do many doctors do it in all these fluids, and it is not very useful. But only in lung conditions it is useful.
Okay. So it was suggestive of an exudative. It was suggestive of an exudative.
It's hemorrhagic fluid.
And hemorrhagic and unilateral, which was more suggestive of malignancy.
Okay.
The fluid is also sent for cell block cytology, which came out to be non-small cell.
Okay. So CT, what is the finding?
The CT also had a soft tissue density in the right medial lobe.
Only single lesion.
Yes, sir.
Single lesion. Yes. There is no lymph nodes.
No, sir.
There is no supraclavicular lymph nodes, scalennial nodes, nothing is there. Okay. So when you have a patient who is having pleural effusion and carcinoma in the lungs, what are other features you look for in this patient? Should be used for any other features. 65-year-old female who is having lung malignancy, pleural effusion, hemorrhagic. Your diagnosis is complete there. Should we use any other things other than that as a postgraduate? Then what your diagnosis is absolutely right, and you can stop the investigation now, and you can go ahead with your IHC or whatever it is. What else you should see?
The features of
Features of
meiosis.
features of Pancoast tumor. You have to look for always look for paraneoplastic syndrome and compressive lesions by the tumor. One is like you told Pancoast tumor. What is it? It is not Pancoast tumor, but it is what is Pancoast tumor?
Small.
So what is the finding you get? What? Horner syndrome. So always look for Horner syndrome, this type of patients. Then paraneoplastic manifestation of lung malignancies. What all things you look in that patient? Hypercalcemia, hyponatremia, altered behavior, low GCS, ataxia, peripheral neuropathy, visual disturbances. So many things you have to look for, because you may not see, once you get a diagnosis, you may not see all these things. But these patients can develop paraneoplastic manifestations because of lung malignancy. They are known for that, especially small cell. This is non-small cell. Okay. Now, how do you proceed with this patient? What will you do for this pleural effusion?
So if it's on repeated X-ray monitoring, if there is reaccumulation of the fluids, we'll have to insert an
ICD is the best thing, because it's a rapidly accumulating fluid with hemorrhagic. This is not going to stop.
Yes, sir.
So you have to put an ICD, that is definite.
And once the drain comes below 100 for 2 consecutive days, we can maybe proceed with talc fluoridesis.
Okay, so you have to go for fluoridesis.
Yes.
Then what is the role of steroids? Is there a role of steroids? Ideally, there is no role, but if the patient is more symptomatic and you cannot treat the primary conditions, then steroids may be helpful to reduce the amount of fluid accumulating. It only reduces the inflammation. It will not reduce, nothing to do with the tumor. Okay, it can give symptomatic benefit to the patient. How do you proceed with the non-small cell tumor in this case? What did you do?
We gave medical oncology.
Okay, so you have to treat oncological treatment also we have to give. And is there any role for radiation therapy?
Depending on sensitivity.
So that you have to see whether, suppose the patient is non-treatable with your oncological drugs, then palliative therapy should be given, that's all. Otherwise, it will be very difficult. What happened to the patient? Is there any malignant deposits in other areas of the body? Did you do PET
CT schedule, sir?
It is not done.
Yet to be done.
Okay. So
The
that
ICD was inserted yesterday, sir.
Okay. So you have to do PET CT and find out any other areas it is infiltrated or not.
Yes, sir.
Okay. How is the patient now?
Patient is symptomatically better and vitally stable. ICD was inserted yesterday. We had to reposition the ICD twice because there was the fluid was not free flowing.
How do you manage the pain in this patient? One of the most painful condition is malignancies, because the infiltration into the pleura, it will be very painful. So how do you manage?
Tramadol.
Opioids like tramadol, morphine patches. So morphine is the best drug, or like you told, tramadol also can work. So that has to be started. Otherwise, what will happen? Pain will be there. What else can happen? Restriction of movement, lung movement. Restrictive lung disease. Most of the patients in oncology ward, if you go, they will have hypoxemia or reduced saturation only because of they are not able to breathe. If you can relieve the pain, they can breathe in a better way. So, relieving of pain is very important.
Yes.
What is WHO pain ladder? This is primarily described in oncology. Okay, cancer patients. WHO pain ladder. You should read about pain ladder, and depending on the pain ladder, when it goes up, you have to have initially paracetamol with NSAIDs, then paracetamol with opioids. Like that, you have to increase. Okay, dose has to be increased. Okay, thank you.
Thank you.